conference. Perfect choice. Spine surgery in the elderly, a challenging decision.
Thank you, Dr. Suhail. We enjoyed so many good talks. I had difficulty putting together this talk, one because of the broad range of variables within the talk and the topic. The other thing is we have heard it all. A lot of so many talks that were great during these 2 days, and I wonder whether I can add something. However, I thought, what can I add to myself in preparation? So that could be an addition to many of the audience. So I have nothing to disclose really regarding this talk. Can I have another disclosure? I don't have all the answers. It's a work in progress. We have seen how Dr. Baaj and Dr. Muhammad and Dr. Khalid, Dr. Sami, and many of our colleagues try to go around the difficulties in dealing with older spine population. So, but first, we need to know what we are dealing with in this country. This is a population census in May 2023 of the Saudi population. And if we agree that in the literature, older population is more than 65 years of age, so that would be 61,849, which is compared to nearly 55.8 million in the US and 90.5 million in Europe. It is like 2.6% of our population, our older population, compared to 16.8 in the US. If you take the Saudis only, that was the total population. If you take the Saudis only, that number drops a bit, but the percentage increases to 3.5% of our Saudi native population are older. It gets interesting that the number is growing, and we will see a sharp growth in the age population in the coming decades. In 2035, the older population will increase to 9.5%. So if in 2035, we are 45 million, 10% of that is what? Is 4.5 million. So you're going up from 860,000 to 4.5 million in almost 10 years from now. In 2050, we'll increase to 18%. In the US, it's projected at 2035 that the older population is at 71 million. And this graph shows how the Saudi population is going to grow exponentially in the coming 2 decades. And look at the distribution of the population in Saudi. We used to think that we are very young population, but that young group is moving up, and we have a waste now in our population distribution, and that waste is going to go up to balance itself into more number in the older population. And look at 2020, the older population number compared to projected one in 2050. Together with that, the life expectancy is expected to increase due to improved sanitation, better medicine, socioeconomic status. And the Vision 2030, one of the pillars, is improve health of the society and improve life expectancy by a minimum of 6 years. And the government is taking that very seriously. So as described by one of the papers, this is an uncharted territory for the magnitude of aging population and their needs. If you think you are seeing many older population in your clinic, guess what? This number is going to double and triple in the coming decade. So how is this relevant in spine surgery? In decision-making in spine surgery for older population, it's a challenge for all of us. And there are demands on the, or time demands on the cost. And I thought to bring cases because I know surgeons in the audience, if you don't see cases, they get bored. So this is a 75-year-old lady, rheumatoid arthritis or methotrexate, hypertensive. She has neurogenic claudication, minimal low back pain, and no neurodeficit. This is her X-ray, and this is her axial at the worst stenosis level. And I wanted this to be like a poll from the audience, but the system doesn't allow. but take seconds to think about it. What would you do for such a case? This is flexion extension. And these are probably some of the options that might go in the minds of the audience. I'll probably push for conservative, but claudication doesn't go well with injections and stuff like that. Decompression is an option. Maybe I want to fix that listhesis level. Maybe I want to have more fixation. So what we did was we decompressed her only. We went at L3-4. We hammered, we opened on one side only, kept the midline intact, and we cut the spinous process at the base and moved it to the side and did a laminectomy. The patient did extremely well. So this is a trial to, if that case was a 40-year-old, 50-year-old, maybe our thought will be a little different. So we keep saying spine surgery in elderly is different, and any one of us would operate on a 75-year-old would be different than a 45-year-old. Does the literature support that? So there are many publications in the literature showing that mortality is a bit higher. So we're not used to, when you look at degenerative disease in the lumbar spine, to see mortality rates. But in elderly population, you would see mortality rates. At 6 weeks, at 0.9, almost 1%. At 2 years, 1.8%. Even the medical complications are higher. They're 9 times higher. And for every age in one study indicated there is 23% risk in developing some sort of a complication. So the more complication or medical complication are associated with how much you do, how much time you take in the OR. However, despite that, health quality of life for that group of patients, they are really good. If you do a good job and the patient improves, they really benefit from your surgery. That is seen in the cervical spine, seen in the lumbar spine. And we have seen Dr. Baaj present nicely that he prefers to go posteriorly, especially in older population because of their dysphagia challenge. The difference in younger and older population is less, though, in decompression alone, understandably, because of less OR time, less instrumentation, less soft tissue dissection. However, the more you do in length of stay, the more you do in instrumentation, you have more risk. Look at this study, 17% with instrumentation, non-instrumented is 8.8%. And the risk goes up as older the patient is. More studies look at the readmission rate is 6.4% within 30 days, up to 20% complication within or overall complication. Adult spinal deformity affects this group extensively, and there is an extensive group of papers in the, describing adult spinal deformity risks and complications, and we have seen very elegant talks yesterday by Dr. Khalid and the group about that. So this study also on adult spinal deformity looked at 206 patients with 2-year follow-up. Interestingly, in this study, that older patients had a worse baseline disability, health status, and more severe low back pain and leg pain. However, at the same time, they demonstrated better improvement than younger population. And this is the list of complications. And when you want to aim for correcting these patients, that rule in the box of mismatch between pelvic incidence and lumbar lordosis, pelvic tilt, SVA, you have to balance that according to the age and modify your target. So it's a balance between what you want to get and what the patient should get. So I will move on for the interest of time. This population is characteristically more osteoporotic, and we have heard very nice session today about osteoporosis and its impact on patients' outcome. Interestingly, if you take other spinal deformity patients, this study reported that 1 in 5 patients regret that they had the surgery, and that's kind of depressing to the surgeon. One of the worst things happens into your clinic, someone comes up and say, I wish I'd never had your surgery. So how old is old? Obviously, the older they are, the more risk of complications and the more innovative you want to be, like Dr. Abdul-Bar has showed with his local anesthesia technique. So can we predict that physiologic age? There are many parameters that have been used. I think frailty is something that has been coming up in the literature. Frailty is the increased vulnerability due to your loss of physiologic reserve, decreased energy, physical ability, cognition, and overall health. And people have shown that frailty index, and they calculate frailty index even for adult spinal deformity, is associated with all risks of complications. So you can know about your patients by doing their frailty index and identify who are non-frail, frail, or severely frail. And you can see in this table that frail patients had a significantly higher wound complication, BGK, major complications, and you name it. Even on the multivariate logistic regression, they had a worse outcome. Interestingly, those who are more frail had more advanced ASD, but the study was not powered or targeted at finding that outcome. Obviously, the more ASD, the more likely they will undergo a complex surgery. So patients with high frailty are at higher risk. So people became innovative and they compared MIS to open, and they found people with MIS do better. Maybe they do better even with the local anesthesia of Dr. Abdul-Bar. What about Saudi? What are we doing with frailty in our population? This is a cross-sectional study done in Al-Kharj area, included 486 participants. And the participants in the study showed a higher frailty than what's reported in the literature. What's reported is 4 to 16%. Our population is 20 to almost 50%. They increase by age, living alone, chronic conditions, cognitive impairment. I think we better check ourselves on the frailty index. So do we have a biologic number that we can have instead of trying to measure it in an index way? This is interesting study that identified that telomere evaluation, which is the region of the end of the chromosome that normally shortens with age, it's shortening degrees associated with common disease of aging and mortality. So people are going towards more biologic way and number to evaluate the frailty. So the decision is complex, and this patient, we did a decompression, and I still go back to the wisdom in this paper that you evaluate the patient based on their clinical presentation and and putting in mind their obviously imaging. So some patients, despite their bad-looking imaging, you may just have to do conservative, or you do a decompression, and the more their symptoms tell you about their condition, the more you would tailor their surgery. So our patient was at a level of level 1, which we did decompression. So a judgment is a complex process, and usually you would judge things based on the process or the outcome and your understanding of the disease pathology. I will give an example. The process is developing a guideline. Cervical myelopathy had a guideline in Global Spine Journal that I certainly follow in my clinic and evaluate patients based on this. And it turned so many patients I see with MRI showing stenosis, but they recorded well on this Japanese Orthopedic Association score, and I did not operate on them. Another thing that helps is seeing the outcome of the trials. We all recall these landmark trials that came on a simple common problem, which is degenerative lumbar stenosis with spondylolisthesis. So try to fix symptoms rather than imaging. I think in older population, you want to be really symptom-oriented and helping that patient overcome that difficulty. This is an 81-year-old blind, diabetic, hypertensive, osteoporotic, had mainly neurogenic claudication, came in a wheelchair. It turns out in January that he had a fracture that got worse, and he had a stenosis right there at L3. So what I did with him, I did decompression. I went from one side, undercut the spinous process, widened his canal, and this is his post-op MRI, and he was happy. He came back later with back pain. He fractured another level. Obviously, along with that, I referred him to endocrine for treatment of osteoporosis. And with that, look at his CT and X-ray. You might think I want to take that patient for a long segment fusion, but what is the risk? The risk is huge. So we said, why not try a single level vertebral body augmentation? And that had went very well, and he recovered his pain. Sami and I did this case, and patient did fantastic. Sometimes you could stage. I thought this 72-year-old coming in with low back pain and claudication, but mainly claudication and lower limb pain, and bad-looking MRI and lumbar lordosis. So I decided to just stage her, do in the beginning L2 to L5 correction of her lordosis a bit, decompress her. That's a 4-hour procedure or a 5-hour. The patient went home, and I told her, you very likely will need to go back in again. And short enough, in 10 months, she got worse. We extended the fixation. So we should understand and talk to patients and understand their perception. This study looked at patients' perception. And the patients think differently. They think I have to have the surgery tomorrow. I am in misery, and the pain after surgery is trouble. How can I go up stairs and go to the second floor? Do I need a bed in my ground floor? What are the tools to help me deciding? The surgeons do not, unfortunately, provide good tools for decision. While we, on the other hand, we worry that the patient's expectation is not correct, and we want to adjust that expectation and calculate the risk-benefit, plus think about technology, awake, local, and all that stuff. So there are cultural aspects that are relevant to us, though. So we know society values. In the West, maybe their older population go a nursing home. It's a shame on us if our parents go to a nursing home. Our older population are highly respected. They are the source of our guidance, wisdom, faith, and love. This is why frequently, or almost always, you find the older person coming in a wheelchair or walking, and the whole family are coming with him. And a lot of times, you have to discuss the surgery with them, not with the patient. And they are probably the one taking the decision, which carries consequences of probably they could feel guilty either way, if not going with the surgery, or if the surgery goes on and they develop a complication and they lose their loved one. So for the future, we know our population is going older. There are no published study on this in Saudi Arabia. I looked, there are good work from National Guardian particularly about juvenile or idiopathic scoliosis. However, we don't have anything in Saudi about the Saudi population. No epidemiologic study, no outcome of elderly, despite all the wonderful surgeries that we are seeing, which I would like to propose, because if we have all this data and we are coming up to an upslope, we probably better come up with a few studies. Some of them are simple studies, like what is the epidemiology of spine disease in those older than 65? What is the outcome of spine surgery in elderly? Take every comer. There was a study about what is the complication of a craniotomy. Take every craniotomy, what is the morbidity and mortality? I think these are doable studies, and we should do them. So in summary, spine surgery in elderly carries higher risk, particularly in older population, frail. If you spend longer time in the OR, more extensive approaches, more instrumentations, could you do that conservative? Could you do MIS? But do not deny older patient surgery, because we know that they benefit a lot from the intervention. Try to manage comorbidities, treat osteoporosis, maybe enhance recovery program after surgery is useful. Psychological support, depression is common in that age group. Maybe you need to talk to them, and they appreciate people when they talk to them, especially yourself. And careful operative approach and planning, and adequate post-operative care. I would like to thank the organizers for really wonderful 3 days. It's been an honor and a pleasure. And I would like to remind you that we carry our 13th spine update on 21-22 December, 1 day of cadavers, 1 day of case talks. And by this, I would end my presentation. Thank you.